Okay, so let's get started. While more people, I'll let people trickle in. Thank you everybody for coming to our first Zoom meeting, our second meeting officially, but our first Zoom meeting for Fuller's ANST, what we're calling our Fuller's ANST lecture series. Our first guest is going to be our very own Dr. Nolty. And before I introduce Dr. Nolty, I did want to say, let you guys know that this meeting is going to be recorded, and I will give you guys more information. We will give you guys more information on where we're going to post the video, probably on the website that we created for you guys, so you guys can view the video on your own time. Um, and so let's get started. So again, welcome. Um, Dr. Nolty is a board certified lifespan clinical neuropsychologist. She coordinates and directs the assessment services at Fuller Psychological and Family Services. She's absolutely passionate about psychological assessment. She loves the privilege of walking alongside clients during the testing process, helping them to feel supported and leaving them standing tall and feeling understood. She is a Fuller graduate in 2003, and then worked at City of Hope National Medical Center for 7 years, where she coordinated the neuropsychology program in their pediatric department. When she returned to Fuller, where she serves currently as an associate faculty member, it was very important to her to provide appropriate scaffolding in real client situations to prepare our Neuropsych Track students for further neuropsych assessment experiences. And she quickly embraced our clinic as a place in which to serve the diverse needs of our community while mentoring graduate students who are passionate about neuropsychology. So, ladies and gentlemen, Dr. Nolty, go ahead and take it away.
Thank you, Juan. It's really an honor and a privilege to be the faculty sponsor for this group. You got to hear me a little bit 3 weeks ago, and now I have the privilege of just opening up and letting you know a little bit more about what my journey has been towards being a lifespan neuropsychologist. And so I'm going to start by just talking about what is a lifespan neuropsychologist. And I think it's best understood within the context of other types of neuropsychologists. So to be board certified, there is one specialty right now. There's a bunch of different specialties. Like you can specialize, you can become board certified in forensic psychology, in rehab psychology, etc. I've forgotten how many specialization areas there are. But within the specialization of neuropsychology, right now, there is the option of pediatric board certification in neuropsychology. And then there's not a specific specialization, but sort of the general track is the adult neuropsychology track. And a subset of that would be the Gero folks. And then there's people like me who could never decide what they wanted to be when they grew up. And that's why I've kind of landed in this lifespan situation, which I really, really, really like. My first career, I don't remember if I mentioned it 3 weeks ago or not, but I was a teacher. My field was mathematics. My first master's degree was in math, and I taught mostly math, mostly overseas, mostly high school. And what kind of led me into the field of psychology was realized I was in New Zealand, and I realized that what was bothering me about teaching were the kids that I would have to ask to step out of the classroom because they were disrupting the other 25 students and it wasn't fair to them. And then just realizing that some kids come into the classroom with so much home baggage that, what am I doing giving them math homework? And I really wanted a chance to take a look at how to help adolescents in particular, who are struggling, who are going to school with just too much baggage, emotional baggage, to trauma baggage, to be able to do just their normal coursework. And I always figured that if the psychology thing didn't work out, I could go right back into teaching. And by teaching, I certainly thought to myself, assumed that it would be back in high school, because I loved teaching. I just really I loved it. I loved the kids. I loved my best teaching years were the years with variety, when I would be teaching calculus and some of the higher classes to the gifted and talented students, but also some of the remedial classes, the rough and tumble kids, the vocational kids. I loved that. And I found that there were some real opportunities in New Zealand, especially, to sort of represent those kids in curriculum development. So anyway, so I assumed that that would be where I would go when I kind of landed in this field of neuropsych. But I started with training at CIML in UCLA in Gero. And that's where the whole world of dementia assessment opened up for me. I had no idea. I didn't know that there was so much richness and so many subtleties in testing people. And I love the elderly people. I really, at some point, grasped the fact that half of assessment is working with the client. The other half is gathering data and doing all the analyses and writing up a report and getting some really good recommendations that can help change the course of somebody's life. But that first half is the in the moment testing. And that for me just really, really came alive very, very early on with the Gero track. And then I don't know how it happened, but I got traded, I think, over lunch. And I had a double clerkship. So my first half of clerkship was at CIML in UCLA. And I think there was supposed to be another track I was supposed to be on, and then it fell apart. I don't know what happened. I just got told that my second half of the year, I was going to be at Harbor, UCLA. So no problem. And I think I got the best of both worlds because I got two very different contexts. In the first context, I mean, really good for my training. I was her only clerkship student. And so I got all the hand holding that you could want. I mean, I got to observe her testing. She observed me testing. There's just a lot of personal help in getting up to speed and really learning how to do it well. And then at Harbor, just a much larger, there were a lot more trainees. So I was just one amongst, I don't remember how many, but we had group supervision. It was just a whole different situation. And medical setting. So the kind of clients that we worked with were very different. And that was fun to just get some variety and see what was going on. I also, congruently with all this, I had a job, as so many students do. I was at Sycamore's Hathaway, and that's an RCL 14 group home for kids, adolescents who are seriously emotionally disturbed. And I was in the data management department was my job, but it was adjacent to the assessment people. And so I also got to do some assessment, and they did assessment with every single kid who I mean, it was a residential treatment center. So every single kid who entered the residential treatment program got assessed, and they were thorough assessments. I mean, it was not just the neuropsych, it was also the behavioral, the personality, the emotional. This is where I started encountering juvenile schizophrenia, um, psychotic bipolar, just some really, really interesting kind of cases. And so that, and of course, with that, I mean, one of the main differences between the different types of neuropsychology specialties, part of it is the type of clients you work with. Another part of it is the tests that you use. So this is where I learned the WISC, which is the child version of the WACE, goes from age 6 through 16. This is where I learned the NEPSI. This is where I learned just a lot of the tests that are commonly used with kids. It's also where I learned more of the personality measures, the adaptive scales. You know, how well is this person able, this adolescent, able to function in the world? I mean, and these were kids in residential treatment at the highest level of care that California offers. So they, first of all, were not able to function in a normal situation in a normal public school. So they, or in their own home. So they'd been removed from their home. Some of them had parents who were involved, some of them didn't. But that was fascinating to me. And that was where I kind of landed where I always thought I would land, working with adolescents. Certainly with more emotional issues than I had ever dreamed I would be working with. I had assumed it would be more the ADHD and the learning disabilities and that sort of thing. I remember one of my most memorable clients of that era was a kid who actually, while I was working there, they opened up, this was RCL 14, so the highest level of care in all of California. And the next level of care was psychiatric hospitalization. So while I was there, they opened up something in between those two levels on the grounds of Las Encinas Psychiatric Hospital. So it was for kids who had been living in the psychiatric hospital to try to give them a group home setting that wasn't quite as intense as the psychiatric hospital. And I remember a kid who his disorder was identity confusion with a cat. And I, of course, love cats. So I loved this. I just found it absolutely fascinating. His dad was a registered terrorist outside of the country. I can't remember what country he was in, but not able, the FBI or whoever had blocked him from coming into the country because of his registered terrorist status. That was his dad, his biological dad. His biological mom had treated him like a cat when he was an infant and very early days. So licking him and treating him like a cat. And then emerged this identity confusion. And he was 14. So he'd been in treatment pretty much his whole life. and so he'd kind of grown out of using his toy box as his litter box, and some things like that. But he would still hiss at the kids, other kids, when he would get mad at them. He would, pull his claws out. And testing him was absolutely fascinating. It seemed like whatever tests we would do, he would the cat in him would come out. I remember the Rorschach, which if any test is gonna raise, gonna accelerate, gonna bring things to the fore, it's gonna be the Rorschach. And I encourage you, I mean, it's not always used, it's not often used in neuropsych settings, but it's a fascinating legacy of our heritage as psychologists. And I encourage you, if you have the chance, to take the Rorschach class, to learn that mindset. And I don't use it currently in my practice today. I haven't used it in quite a while, but I like the fact that I learned how to think in that way. And I think that's been very, very valuable. It's helped me learn how to interpret projectives and to incorporate that into my conceptualization of cases that need that extra personality, emotional connection. So anyway, this kid, and I'll wrap up with him. I remember when he got to one of the cards, and he just regressed. He was just like and he's 14, kind of a big kid. But he just kind of started acting like an infant. And he put the card in his mouth. I mean, think cat. So he's like biting the card. And I just started, I mean, I responded in kind. I mean, that's when your therapy skills, your clinical skills have to take over. And just he was an infant in that moment, just needing me to respond as a clinician to a regressed person. And that was one of my most powerful moments, or a very, very powerful moment in my trajectory as a neuropsychologist, that realizing that in our actual testing, we encounter people in their areas of extreme vulnerability, whether it's emotionally or doing math or whatever, in their memory. I mean, for people who are struggling with cognitive slippage in their fears of having dementia. And that if we can be with them, if they can see us as an ally, as somebody who can understand them in those areas of vulnerability, that it can, I mean, the clinical therapy that can happen during the course of testing can be very, very, very powerful. And so that's always one of the main, I guess when I teach neuropsych, it's not just about gathering data as quickly and easily as you can and putting it together, conceptualizing, writing a report. I mean, all of that is super, super, super important. But it's also just being with people in their areas of vulnerability. And we all have them. And most of us don't embrace them. If we're not good in math, we don't become an engineer. If we're not very athletic, we don't do anything, we don't do athletic pursuits. We certainly don't become an athlete. And so I think that there's something very, very, very human about shying away from the things we're not good at, or avoiding them, or just not paying attention there. And it's when we do neuropsych, or when people are forced to face their darkest fears, that they come to us. and that we are asked to, I mean, contain that anxiety always. There will always be. I mean, we're all graduate level scholars, and we get anxious when we take tests. And it's going to be only worse if there's a real fear that somebody's going to find dementia under it all, or whatever the case may be. So yeah, so I started by just talking about my formative experiences. Um, Internship was mostly clinical work, very medical. I was at Loma Linda University Medical Center, so working in the cancer the ward, working in a heart clinic, a lot of just medical issues. But there was also some neuropsych. Um, and that was very different types, again, just exposure to mostly adults, a few adolescents, but very different issues and situations that were also very, very compelling. So I remember a young man who didn't have much intellectual potential. And so he would go to his next door neighbor, and he was living on his own. He was able to live independently. But he couldn't really hold a job. He didn't have the wherewithal, or, I mean, I don't know how he slipped out of high school without somebody getting him in a vocational program, but they hadn't. And his neighbor would give him odd jobs. And that's how he was surviving, from cutting this neighbor's grass. And so the neighbor realized that he wasn't always going to be able to be there for this young man, and that this young man needed more help. And he was willing to pay to get the neuropsych done to figure out how he could get SSDI, disability, Social Security, which is pays more than just regular Social Security, and it also you can acquire it when you're younger if you meet the criteria. So that was again very, very, very different case from anything I'd done before. And so just all these different cases. So I kind of emerged from internship, honestly, not knowing what I wanted to do when I grew up. I knew I wanted to do neuropsych, but my dream of working with adolescents had kind of broadened through those different experiences of neuropsych. So, and I knew I really liked the medical setting. One of the things that comes along with a medical setting is that people aren't there for psychological assessment. They're there because they have cancer. They're there because they have heart disease. They're there because they've got epilepsy, all kinds of issues. And one of the services that medical facilities can provide is neuropsych, to help figure things out in different ways for different kinds of situations for different people. And I loved that. I loved kind of being backseat. I mean, when you need to catch somebody, you find out when they have their medical appointment, and you see if you can schedule meeting with them around that. And you learn to kind of juggle things, because it's not about you, it's about their medical issues. And the neuropsych is supportive of whatever is going on. The referrals come from the medical doctors, by and large, because they need help in figuring out the course, the direction for their patients. So I knew I wanted to go into a medical setting, and some of it is just letting your life unfold. It's like, okay, what does God have in mind for me next? What is my best decision right now, given the cards that are laid out in front of me? And that was City of Hope. I didn't apply to City of Hope. I wanted a neuro to work under a neuropsychologist who understood um, the value of human beings, the value of humanity, that it's not just about making money, it's not just about crunching numbers, it's not just about churning out reports. Um, and so I had listened to all my classmates and connections and figured out that I really wanted to work under Dr. Sunita Patel. At that time, she was at Children's LA. And so and again, always thinking I would be working with adolescents and kids, I applied to work with her because she was somebody I wanted as a role model. I wanted as a mentor in my journey. And then turned out that she was changing jobs and relocating herself to City of Hope, and asked me if I wanted to join her as her postdoc fellow. And I was, of course, I wanted to work with Dr. Patel. And so it didn't really matter to me if she was at Children's, if she was at City of Hope. But turns out City of Hope, that the commute was a little bit easier than it would have been to Children's. So there were a few advantages like that. And so I landed at City of Hope. And then the other thing that happened was 2 weeks before I started, the neuropsychologist at City of Hope left. And she had already brought on board trainees, clerkship students. I can't remember if they were all Fuller students or if they were from other schools. And I can't remember how many there were, but I think there were 3 or 4. And she disappeared. And I personally have pretty strong feelings about setting things up for other students in an academic setting and then leaving. But she didn't see it that way and probably had personal reasons that certainly I wasn't privy to. But so she left. So as a postdoc, I ended up in a situation of running the neuropsych services at City of Hope in their pediatric department under the supervision of Dr. Sunita Patel. And I just hit the ground running. I was really, really grateful for the training that I'd had at Simmel, at Harbor UCLA, on internship, because I needed absolutely every bit of it. The clientele were different, and that ended up, my postdoc was a 2-year postdoc that just kind of turned into a staff position. So I just, nothing really changed. My title changed. I got licensed. And I ended up being there 7 years, just running their neuropsych services. A lot of what I loved there was that it was lifespan. It was, strictly speaking, it was on paper, it was in the pediatric department, which it was. So a lot of kids. And the reason for that is that the most common type of of cancer for kids is leukemia. Leukemia can attack the brain. It sometimes does right away. That's kind of rare, but there's always the possibility of it migrating to the brain. And so the treatment that they give has to be designed to protect the brain. And so they give chemotherapies that are designed intentionally on crossing the blood-brain barrier. And that's that may be necessary, and I certainly believe it is, to save people's lives, because with chemotherapy, appropriate chemotherapy, the lifespan of children with cancer has, just drastically changed. So that it's no longer a death sentence. I mean, you go through the chemotherapy and you can be cancer free. And we all probably know people who have had childhood cancers who are cancer free, living normal lives. But because of that, chemo crossing the blood-brain barrier, they always needed neuropsych testing because a developing brain is going to be impacted by the chemo. And kind of in reverse, I mean, the early brains are more plastic, and yet they're affected more. And so the younger a child is when they get chemo for cancer, the more damage, the more fallout there's going to be than if the brain is, the older adolescents where the brain is more mature, more completely developed, had far less fallout from the chemo. So, yeah. And then there were also severe cases of cancer. I mean, there's also brain tumors that, of course, affects the brain. And then situations where kids need bone marrow transplants, and that's not a treatment of first resort because the mortality rate is really high. I mean, the odds just shift dramatically. And so anybody going through bone marrow transplant, first of all, they have to have full body radiation prior to the transplant to just kill off, it's a last ditch effort. Let's kill this cancer and then move on, transplant the bone marrow so that the people can live cancer free. But that full body radiation is also brain radiation, which isn't kind to the brain. And people don't know if they're going to make it. I don't know. I've forgotten what the odds are now, and it would depend a little bit on the situation, but sometimes they can be really low, like only 10% chance this kid's going to make it. And so I would do pre-bone marrow transplant neuropsych evaluations. And I loved doing them love is not the right word. I found there was a lot of satisfaction in doing those. Usually there was very little warning before they went to transplant. I mean, once somebody got in a position where they were in remission, then it would be okay, 1 week till bone transplant. And so then you would have, just you'd have to schedule this, and they had all kinds of other medical appointments. And so you're working in between. They're not feeling good. They're fatigued. A lot of times I did those neuropsych evals on the day they were admitted to the hospital for the bone marrow transplant. And needless to say, they never would have gotten a good night's sleep because they're too anxious. They can be nauseous, just fatigued, not doing so well. And we would have to get everything we could get in 2 hours. And that was just about the maximum time there could be. And then we would gather the data. So this is not ideal situations. But the idea was, even under conditions that are not ideal, what strengths emerge? If somebody has a good strong IQ of 120, well, that's of course an underestimate of their IQ, but now we know their IQ is at least 120. And so what usually happen, we'd write up the report and then we'd back off, let the medical stuff happen. Sometimes they were in the hospital from 4 to 6 months. And then they would emerge and need to go back to school. And so that's when we would provide the feedback session And that's when we could help set them up for success going back to school. That's when we could talk to them about what their strengths are cognitively. We could talk to them about what the effects would likely be of the chemo. And a lot of times that would be reduced processing speed, difficulty with working memory, a lot of stuff like that. So we could kind of set them up for a chance at getting back to a normal life in the classroom. And then quite often, we would do testing again a year later or 2 years later, after they were in the classroom to find out, well, what's going on. Sometimes it was a matter of figuring out, do they just need extra tutoring to help them get up to speed with their peers? Or is it really different now and they need special education classes? It's not fair to ask people to be in a regular classroom when they just can't, when they don't have the cognitive capacity to do that. And so a lot of times those were just really poignant, and it really felt each and every time like you were really helping somebody make a difference in their lives and make a go of it. Even I remember one case, his mom called me. He was like 18 and he'd been accepted at Harvard to go to college to study math. And his mom called. He'd gotten leukemia over the summer before going to Harvard, and had to come in for a bone marrow transplant. And he was just sick at the thought that he might not be able to do math. With a lot of kids, if you miss a foundational building block of math, it kind of is crumbles. So a lot of kids with ADHD have trouble with math because they can't pay attention all the time. So they miss something the teacher is saying. And then it kind of slides from there. And so it's same thing with the results of chemotherapy, that given that it kind of messes with your processing speed, your working memory, your concentration, often math would be affected. And so they had been told that, he maybe should just change fields. Math is going to be really hard for him. And so his mom called to find out my opinion. And I said, well, respectfully, to the physician who said this, I have to disagree, because I don't think it's the math that gets shaken up. I think it's all this other stuff that, especially in a younger kid, can cause problems in something like math that's so sequential. And for an 18-year-old whose brain was already very developed and who had strengths in math, I felt like that was going to be probably the most resilient part of his brain. And so we did testing. And he was, of course, very impressive. And even like super impressive. Like, there's Harvard level, and then there's above Harvard level, like super Harvard level. And he was kind of at that like amazing level. And I remember doing feedback with him. I don't remember why. I just remember that we did it walking across the campus because he had an appointment in a different building. And I'm like, I'll just walk with you. And so we were just casually talking. And I was explaining that it was probably going to cause him his processing speed would be slower. And he would probably get to Harvard and look around the room and feel like, he didn't belong there, that everybody else was catching on faster than him. But that he should know that he absolutely had what it took. And of course he's into math, so I could share those numbers with him. And he got it, he got the statistical underpinnings of the neuropsych data. And that's turned out to be exactly what happened. So, I mean, all this cancer journey took him a year off of going to college. So it was only the year after that that he went to Harvard. And I, one day out of the blue, got a phone call from his mom saying that he was doing really, really well and how grateful they were that I had been there to really encourage him to keep going down his path and to caution him for those areas where he would have to watch out, where that would be different from where he was before. So that was, I mean, it happened kind of both ends of the spectrum. The super bright but terrified that my life dream of being a mathematician is now ruined, all the way because cancer happens to absolutely, it's no respecter of ethnicity or SES, anything. So definitely had the cases of people with far lower IQ, just very, very different. And I grew to absolutely love those patients as well. I love being in the moment of assessment, getting to know the person that I'm testing. And like with that patient who's super bright, I mean, you can read the instructions really fast. I mean, show him matrix reasoning and he knows what to do. And so you just get things up to speed for him and just, kind of fly through stuff, tearing the cover off the tests. And then at the opposite end, you learn when people are asking you to repeat the instructions or just looking at you like I'm supposed to do what? And you learn to just slow down. And it becomes a whole different dance where you're just meeting people where they're at, giving them the breaks they need, remaining in control of the situation. Adults usually let you fumble around because usually they we're all kind of raised to be nice to people, and so an adult typically will let you fumble your tests, and they just sit there and you ask them if they need a break and they say no, we can keep going. Kids, on the other hand, especially those kids that I had at Sycamore Hathaway, if you're not good at your craft, you've lost them. They're under the tables or out the window. And I literally mean that. I had one kid jump out the window and he was on a one-on-one. So he had it because he had been suicidal. And so there was somebody assigned to him who was waiting outside. And that was his safe person. So he ran to his safe person and flopped down on the grass. I grabbed some testing materials. I figured, well, if we're going to be outside, we can do questionnaires. Grabbed some testing materials, ran outside, and he was lying on the ground. I'm like, you okay, buddy, if we just keep going a little bit? And he's like, yeah, and his safe person was there. And so I just did questionnaires with him. But I guess what I'm saying is that there's always a dance. There's always an interaction, and it's never the same. And I love that. At City of Hope, I mean, it was the Pediatric Department, but there's also plenty of survivors of childhood cancers. And so I also found myself testing a lot of young 20s, even into 30s, and people who get leukemia when they're a little bit older. And because it's a childhood cancer, it's best treated by the pediatric surgeon, not well, physicians. And so they also needed to be tested. So then I ended up doing young adults. And I loved that it wasn't just kids, but it was also, and this is where I started thinking of myself and identifying as a lifespan neuropsychologist. Another issue that would come up at City of Hope were little kids. It's pretty common for toddlers who spend a lot of time in the hospital to be delayed in their speech. And I think their little bodies and their little brains are so busy healing and dealing with things that normal toddlers don't have to deal with, that somehow that speech just doesn't come online as quickly. But there's other reasons that kids are delayed in their speech, one of them being autism. And you're better off having services, interventions, the earlier you can identify what's going on. And so I would get 2 to 4 year olds, and that was a brand new territory for me. And I I still have to say I kind of have a love-hate relationship with anybody under 5 that I'm testing, because they are wiggly and they do get up and move, and you do have to know your stuff. And you also never know what you're going to get. I think one of the main things, one thing I've come to realize is that kids who go to TK or kindergarten, preschool, they get socialized into doing what the teacher's asking them to do. And kids who have not been to preschool or kindergarten, they just don't have that. I mean, and they may have, honestly, really, really great parents who are providing an enriched environment, but it's about them. Whereas in the classroom, it's about the group. And so when you get kids who haven't been able to go to kindergarten or preschool because they've been in the hospital, when you're testing them, a lot of times they don't know they're really supposed to do what you're asking them to do. And so you're showing them matrix reasoning, you're trying to do your test, you're giving them instructions, and they can so easily just tell you they don't want to do it. They don't like your game. They'd rather play something else. They usually want to stay and play. I mean, they usually like the attention, but they don't necessarily want to do what you want them to do. And there, I think I learned a lot of tricks with little kids. I remember one trick that was taught to me by one of my trainees, one of my clerkship students. He had a little kid just get up from the table, flop on the floor, and say, I don't want to do this anymore. And so the clerkship student grabbed the groove pegboard and followed him and said, okay, let's not do those tests. We'll do something different. Let's put these groove pegs in the groove pegboard, and I'll time you and see how fast you can do it, like this. And then he showed him how to do it. He followed, gave him the instructions, and the kid was so into it, he was just doing groove pegboard. And then the clerkship student said, okay, are you ready to get back to testing? And he's like, okay. So he gets back up, goes back to the table. They resume normal testing, and the groove pegboard test had been completed. Check that box. So I also learned just a lot of the creativity that can happen with little kids, and the value of so many of these questionnaires that it's the information from their parents that goes into the report, that goes into the understanding, that helps you conceptualize. So just the value of collateral information in all of this. So my City of Hope days came to a close. I transitioned to Fuller, never dreamed I would be back in teaching, but at the graduate level. I mean, that was just not on my radar. Um, but at City of Hope, I worked with clerkship students from Fuller. And one of the first things I had to do was help students realize that if you stay in your manual too closely, you lose rapport with the client, that there's a balance. And so I always say it's kind of like skiing. If you're not falling every once in a while, you're not pushing yourself hard enough. So you got to be taking risks and falling every once in a while. If you're testing, you got to make a mistake or two. Because if you're playing it too safe and staying in that manual too much, then you're going to lose the relationship with the patient or the client. So my thinking was go back. So I was always having to, I mean, Fuller students, all of you, very, very dedicated, very responsible. You're known for this in the community. And that's one reason why training directors really, really appreciate and value Fuller students. Fuller students seem to have a greater sense of mission, a greater sense of purpose, greater responsibility, greater dedication, all these kind of good things. And it's also what leads them to try to do it so carefully that they aren't really meshing with and connecting with their clients. And so I wanted to just come back and try to set people on a path of really becoming skilled neuropsychologists, really from the get-go. So I came and I started teaching those intro to assessment classes, which I just loved. And I encourage you to, it starts there. That's what the foundation is. And then I moved on. I became board certified, started teaching the neuropsych classes, and then this possibility for me opened up at the clinic at FPFS. And that has been just a dream because, again, it's a situation where I can be a lifespan neuropsychologist. It's not just kids, it's a lot of kids. It's not just kids, it's also adults. I also get geriatric patients. I've since I have had the connection with City of Hope, I started getting situations where physicians would have cognitive slippage. And the question would be, do they need to retire? Is this serious or is it cognitive overload? Because all of us are cognitively overloaded and all of us do dumb things when we're cognitively overloaded. And so is that the kind of cognitive slippage we're talking about, that you just really need a good vacation? Or is it the kind of cognitive slippage that suggests that you need to not keep working with patients so that you don't make the kind of mistake you would regret? And I've had both of those situations with physicians. And then COVID. There are so many kids right now who need testing. And I think it's the fallout from COVID, because COVID worked fine for some kids. You know, they could work over Zoom, they could do their homework, they had parents who would oversee it. Then they went back to school, carried on. For other kids, it didn't work. And these are kids with ADHD. They just couldn't pay attention over Zoom. These are kids who didn't have parents who were able to be there for them. You know, plenty of parents have to work. And, you know, it wasn't always from home. It wasn't always in a situation where they can monitor the kids. And so some kids found themselves going back to school and things just haven't been the same since. And I think we're still getting that fallout. There's just a lot of kids. We get a lot of ADHD. We get a lot of, there's more and more autism, subtle autism. And I don't know how much of that has always been there. We just didn't have the best tools to detect it or the best interventions to work with it. But getting just kind of a lot of that kind of stuff. Get some really bright young adults who have had ADHD and kind of struggled their whole lives. And it finally catches up with them. And they need accommodations. Had somebody call me last week, needs accommodations for the MCAT, to go to med school. Obviously, I would assume very bright, but it's caught up with them. So we get a lot of that kind of stuff. But we also get, and I love this too, cases where we need to do personality evaluations, emotional evaluations, along with the neuropsych. And that combination also kind of keeps things interesting, to put it mildly. So we're right at 7 o'clock. That's kind of where I've landed, and I kind of love where I've landed. I think it's for me, it could never really decide if I wanted to focus on adolescence or much broader. And it's not every site where you have the opportunity to do both. A lot of sites are purely pediatric or purely gerontology or purely adult. So I just feel very, very privileged to be in a place where I still haven't had to decide what I want to do when I grow up. I get to just do neuropsych with whatever comes my way. And to work with clerkship students, pre-internship students, because I think that's, for me, the team approach is really, really fun. I love doing interviews where it's not just me and the client. It's students with me and the client. I love doing feedback where we're all in it together, providing care for the client. So those are, yeah, that's some of what I have loved along the way and what I've done along the way that's really enabled me to embrace this identity as a neuropsychologist, as a lifespan neuropsychologist, and to love it. Any questions or thoughts or before we wrap up? Thank you very much for letting me just kind of share my journey with you.
Thank you so much, Dr. Nolty, for sharing with us. If you guys have any questions, you can go ahead and unmute yourselves and ask your question, or if you're a little shy, you can go ahead and also post your question onto the group chat, to the chat. But my question was, can you tell us a little bit about your research interests, Dr. Nolty? I don't know if you meant.
Sure. One thing I forgot to say, Juan, is that also on my journey, I ended up in my Prac 2 in Torrance, at Rancho Los Amigos. And I was working with a supervisor who worked in Spanish. And she was very, very, very protective of her clients. And so if anybody was a repeat, she wouldn't let me test them because they were hers already. And so I watched so many assessments being done in Spanish, and I got to do a few. At the time, I was really, really frustrated that I wasn't getting to do more. But in retrospect, it was one of the most valuable pieces of my training ever, because I got to just watch a professional do neuropsych who had that connection with the clients, so much so that she couldn't release it. But that was really, really, really valuable to me. And so I really want to encourage any of you who speak any other languages. Um, to put that down as something that needs to be done, because the field is so young, and we don't have enough neuropsychologists to do testing in other languages. And it's really important. I mean, there's a need for tests to be validated. There's a need for tests to be used in so many, different scenarios, because they may have been normed in one tiny little way, but need to be broadened. So yeah, sorry, Juan, I deviated from your question about my research to say that, because that is something that's really important. We've done a little bit of testing in Spanish at and that's how I got into doing some forensic work, working under somebody from UCLA, because I could do testing in Spanish. And that was great. That was my introduction to forensics, because I was under him, which was a great way to start, not putting your own self on the line. But then, yeah, just doing the testing in Spanish and going along there. So, my research interests, it's kind of like my neuropsych interests. I just have a lot of them. I love research. I think that comes from my math background. And I mean, one thing that's been really fun in the lab, we started virtual reality testing and so we're doing that. It's a classroom, virtual reality classroom, where it's the headset, it's the virtual reality, and kids have to respond pressing the space button when they see an X followed by, or it's an A followed by an X. And meanwhile, there's all these, there's a kid in the classroom turning around asking to borrow a pencil. There's something coming over the loudspeaker. There's a car honking its horn, and you can turn your head and look out the window. So that's been really fun. And that's a collection of data that's going to be ongoing for years. A very easy sell. I mean, all of my clinical clients that I'm testing for anything, I just, you always want to find out about attention concentration, and it's virtual reality. So I haven't had anybody say they didn't want to do it. And so, yeah, so that's one of my research interests. Along with that is the cognitive disengagement syndrome, which I believe will be a part of our DSM with an upcoming edition. Very young, but I'm fascinated by the differences between cognitive disengagement syndrome and ADHD. It's like there's a lot of overlap, but there's differences. And so what are those differences, and what can you do about it? And that's Juan's dissertation, looking at some of the interventions, the recommendations. What can we do for this, what used to be thought of as a variant of ADHD, and now it's thought to be its own thing. So I love that. On the other end of the spectrum, the dementia research. At HMRI, I work with Shaya and Kate and Sarah Lee, doing testing with a longitudinal aging study. And just the odds are, some people slip into cognitive impairment, into dementia. And so just being able to study some of those biomarkers, and we're the neuropsych piece of that. And so we always get to look at neuroimaging. Yeah, and I
Yes.
have other research interests, but that's some of them.
Thank you so much, Dr. Nolty. And we have a few more questions. Kate asked if you were board certified in clinical neuropsychology or pediatric neuropsychology.
I am board certified in clinical neuropsychology. Pediatric is a subspecialty, so everybody becomes board certified in clinical neuropsychology first. And then there's an additional test that you can do in pediatrics And I could have been part of the standardization sample for that when they introduced it. But they had the conference the same weekend as we had graduation. So I couldn't go to the conference and I didn't get to take that test. And then I'm a lifespanner anyway. So yeah, I just stuck with what I've got and that's where I am. But that's a great question. I mean, I think anybody who is interested in truly specializing in pediatrics should go for the specialization, the board certification in pediatrics.
Thanks for clarifying that.
Oh yeah.
Our next question is what drew you to teach at Fuller?
I think the same thing that drew me to come to Fuller as a graduate student, it's the integration piece. I mean, that's what everybody says. But yeah, really wanting to live out my faith. And wanting to do it properly, to do it appropriately, to do it intentionally, and not just on the side, as you would at a different kind of an institution. I would say that what drew me back is probably the quality of student that Fuller attracts, that deeper realization that it's not just a profession. It's not just so you can make money. It's not just so you can, do a job, that there's people whose lives you're changing. And that deeper dedication, that deeper sense of vision, that deeper connection with God and God's people. The social justice issues that abound in this field. That's what drove me back to Fuller. It's to work with people who have values that are similar to mine, who really believe that we can help our world be a better place. So yeah, that's part of it. I mean, there's all kinds of other things. I love my colleagues. Yeah, oh, and it's familiar. I mean, having been here, I hope some of you will come back and teach. It's fun to help. It's not a perfect place. It's fun to help it be a better place. And to just be a part of its own transformation. A part of that journey.
Another question, Dr. Nolty, is where have you experienced that integration theoretically?
Where have I experienced what? The integration in neuropsych?
Um, can you please clarify?
Oh, that integration theoretically.
Yes.
Amir, do you mean in neuropsych?
Yes, in neuropsych. So my question is, in that field where we may have a conversation about clinical practice and how do we integrate different models of practice and our theology, where have you seen that intersection come alive in what people are studying? Does that make sense?
I think so. I think that I most see it come alive in populations that people work with. I come from a Mennonite perspective, which is very, very social justice. It's like live out your faith, feet on the ground. And so I love people who are, sometimes it's pro bono work. Sometimes it's working with people who are homeless. I mean, one of the contracts that Dr. Kosi is getting at FPFS is with the Dream Center, which is residential placement for people who don't have housing. And so I really see, in that calling that Jesus calls us to reach out to people who don't have some of the advantages that others of us have had, and to really walk alongside them. I see that very practical, working out in the practice of neuropsychology. I mean, sometimes it's more blatant than other times, but I always think it's there. Yeah. So City of Hope had a lot of, I mean, the variety of people who end up with cancer, through a lot of people. It bothers me sometimes. I mean, one way I'm not able to fulfill what I would see as my calling, is the fact that we have to charge money at FPFS in order to keep the clinic afloat. And we charge less than anybody else around, but it's still not affordable for some people. And so the flip side of what you're saying, and I don't know how to get around that, except that I know Dr. Kosi is trying to get grants to do some things about that. But yeah, I think it's in walking alongside people in their points of vulnerability that I really feel like that's living my faith. Does that get at the essence of your question? I think your question might be broader than that.
Yes, it covers an aspect of it. I think that is more of practice. I was thinking more of maybe along some philosophical undertones of neuropsychology and how that impacts theology, but maybe that's beyond the scope of what we're talking about right now.
I think that's, yes, something for me to continue pondering. And I think Dr. Brown is probably your person for asking that question, because he's really intersecting, I think, some of the deeper philosophical brain issues, that are, I mean, that's kind of been his part of his life's work. So yeah, catch me at another time. I'll have a better answer for you. But thank you for that. Thanks for that question. That's a provocative one that I really appreciate.
Thank you, Dr. Nolty.
And I have one more question, Dr. Nolty. Currently or in the future, will your lab be doing any research in the area of discrimination and/or culture?
I don't know. Yeah, I don't know. That's a great question. I never know exactly where we're going to land. I mean, right now we have some strong focuses. I mean, one focus is on children of the night. So that definitely enters into that realm of discrimination and culture. But yeah, I don't know, but I'd love that thought. And I also am very aware that we're going to be getting another neuropsychologist on board at Fuller. And so my hope and dream would be that their research interests, and active research grants would be in those areas of discrimination and/or culture, because I think those are areas that are close to my heart and ones that I see as critical for our society. Great question.
Thank you for your answer. I appreciate it.
For sure.
Well, thank you again, Dr. Nolty, for just being here with us and telling us a little bit about your story, and yeah, thank you for the support that you give us as our advisor and as our professor, faculty. Again, we're very grateful for you, to have you.
Thank you.
Before we So before we end, again, I wanted to remind you guys to fill out the attendance just for our just so we can have your information in our records. And then a few announcements. Our next meeting is on Monday, November 4th. It's going to be in person in room 130. That's the room that we were in last in the first meeting from 3:30 to 5. We're gonna do some neuroanatomy stuff. So just come and learn with us, or we can all learn from each other as well. So if you're good at neuroanatomy, come in and help us out and learn a little bit more about the brain. And then our next Zoom meeting, we're gonna have Dr. Brandon Byron. He is a board certified clinical neuropsychologist. His interest is, or his specialization is forensic neuropsychologist. He serves as a director of psychology training at all of UCLA Medical Center. And I think he's also in faculty with UCLA. So the only difference with this, since he's on Eastern time, the instead of doing at 6, we're going to be starting at 3:30 to 5 via Zoom. And we're doing November 18th because it's the week before Thanksgiving week. And yeah, if you guys have any questions, please don't hesitate to email me, email Edita, Nicole, or Surly. Or Dr. Nolty as well. And we appreciate all of your guys' time and being with us. And if you guys don't have any other questions for Dr. Nolty, now you guys are free to go. And again, thank you so much.
Thank you, Sarah Lee. Thank you so much. You guys were the best audience. I really appreciate and appreciate this opportunity.
All right.
Thank
you, everyone.
Dr. Nolty.
Thank you.
Bye.
Thank you, Dr. Nolty.
Thank you. Thank you.